All right, thank you all so much. Can you all hear me okay? All right,
Yes.
great. So welcome everybody, and thanks Rod and Ronnie and Kai. It's great to be here. I'm going to be talking today about Lewy body dementia. Um, it's a fairly complex topic, and I'm going to try and do justice to it. Some of the slides might be a little more complicated, so I apologize for that in advance. Uh, Before we talk about Lewy body dementia, I would like to know, uh, let's see if I can advance my slides. Here we go. All right, so I have no disclosures relevant to this presentation. And before we go any further, I would like to know who is in the audience, who I'm going to be working with today. So let's do this question first. All right, so it looks like we have social workers, QMHPs, we have a sprinkling of nurse practitioners and clinical psychologists, looks like one each. We have some case managers, and we have 12 people whose roles are not listed. So hopefully I have something for all of you here. Thank you for providing the information. Um, So why are we all here today? We are going to be spending 2 hours together. Why are we doing this? So sometimes patients and caregivers can give us information in a much more palatable way than we ourselves can. So this is a first-person caregiver account that I have found very moving. This is about a public figure. Some of you may know who this is when I bring it up, so please don't share it in the chat. I will talk about this at the end. But this is the account, and this is why we are doing this today. Okay, let's see. As you may know, my husband had the little known but deadly Lewy body disease. He died from suicide in 2014 at the end of an intense, confusing, and relatively swift persecution at the hands of this disease's symptoms and pathology. He was not alone in his traumatic experience with this neurologic disease. As you may know, almost 1.5 million nationwide are similarly suffering right now. This is why we are talking about this today. Um, Before we go any further, I would like to bring up a real case. I was telling folks before we began today that I saw this patient in my clinical practice at OHSU just about 2 weeks ago. When we see people in our practice, they're initially referred to us, and then the referral comes to us on email, and we have to approve it before we actually get to see the patient. So this is the synopsis of the case I received on email, that he is an 3-year-old divorced Asian male veteran, that he is being referred for dementia, visual hallucinations, and sleep problems. He has had a progressive dementia for at least 3 years now. He was living independently, had to move in with his daughter in November 2023, so just last year after he crashed his car. He was also falling, not taking good care of himself, and then after the move, he wandered out into the snow in the middle of the night in Jan of 24, and he got lost and was found 12 hours later, about 3/4 of a mile away from his daughter's house. He was taken to the ER. He was treated for hypothermia and a left hand fracture. So this is the information I got on email. We're going to talk more about this case in the second part of the training today, but just based on this, I want to see what your initial diagnostic impression is. So let's open up this question. All right, so looks like about 58% of folks are not able to make a diagnosis, and the diagnosis, the initial diagnosis of the rest of the folks is pretty evenly divided between the other four options. All right, good. Uh, so the agenda for today is going to be something like this. We're going to be talking initially about definitions in epidemiology, clinical features, office screening, diagnostic biomarkers. Then we'll take a short break. And then we'll do diagnosis and differential diagnosis. We'll do the case study that I just talked about and end with treatments and resources before we take up questions. Like I said, it's a fairly complicated topic, so I have some redundancy built into this. So the first part of this is going to be a little bit heavy, but then after the break, we'll come back and review the same topics and try and apply it to a case so that all of you are familiar with the diagnostic features of Lewy body dementia by the end of the training today. Okay, so let's begin with definitions and epidemiology. So all of you know this, but I need to start with what is dementia. And dementia, as all of you know, there are four basic elements to the definition. There has to be cognitive decline. The person has to be alert and cooperative, so you are able to test them, which means that they cannot have a delirium. The cognitive decline has to result in functional impairment, and the cognitive decline cannot be better explained by a primary psychiatric disorder. The last element is controversial, but I'm not going to get into that controversy right now. And then, as we all know, DSM-5 onwards, we are calling dementia as major neurocognitive disorder. The exact definition of that is a little bit different from the definition of dementia I have up on the screen for you. So in this training, I'm going to call it dementia because most of the research has still been done using the older definition of dementia and not the newer definition of major neurocognitive disorder. Then what's mild cognitive impairment? So mild cognitive impairment is when there is evidence of cognitive impairment. It can be reported by a patient or an informant or noted by the clinician, and there is objective evidence of impairment in one or more cognitive domains, but there is preservation of functional abilities and there is no dementia. And this is now called mild neurocognitive disorder, DSM-5 onwards. But again, we are going to refer to this as MCI. So you'll be hearing a lot about dementia and MCI today. Okay, now it becomes a little bit more complicated, so please bear with me. I have to bring this up because the topic of the training today is Lewy body dementia. So we have to talk about what Lewy bodies are, right? In order to understand Lewy bodies, we have to understand the synucleinopathies. Alpha-synuclein is a protein. It's very abundant. It's a physiological protein that is present in brain tissue and in multiple other tissues in the body. And when there is a problem clearing alpha-synuclein, it begins to accumulate in the body tissues. And when it accumulates, it starts to become misfolded. And these misfolded aggregates start to add up in the brain tissue, in other parts of the body. And the aggregations can, of course, occur in many different locations, depending on where this alpha-synuclein is physiologically located. So the aggregation can occur in the brain cells, which are known as neurons, as all of you know. When the alpha-synuclein accumulates in the brain cells, it forms Lewy bodies, and you can see one of them up on the screen. It can also accumulate in the neuronal processes. So these are the processes that come out of the brain cell, which are known as neurites. And so these then are called Lewy neurites, and the picture is up on the screen for you to see as well. And then, like I said, it can also accumulate in other tissues. So in the glial cells are the connective tissue of the brain. It can accumulate in the axons. It can even accumulate in peripheral tissue, and then they are not known as Lewy body. They're called something else, which we're not going to talk about right now. So now let's try and understand the relationship between synucleinopathies, Lewy bodies, and Lewy body dementia. So when you have these misfolded aggregates of alpha-synuclein, the diseases that have that are all collectively called synucleinopathies. So that's the collective umbrella term. Under synucleinopathies, you have the aggregates happening in the brain cells, forming Lewy bodies and Lewy neurites, and that's Lewy body disease. I hope you can see my cursor up on the screen. Then within Lewy body disease, you can have cognitive impairment absent, or you can have cognitive impairment present. I have mostly absent in this box because we'll talk about this in the next slide, because there are some cases of Parkinson's disease where you can see cognitive impairment right from the start, but that's sort of it's not an exception, but it's a minority of cases. But for now, we'll talk about this box where there are Lewy bodies and there's cognitive impairment present. And that is what we call Lewy body dementia. So now we are in this box. And then under Lewy body dementia, you have dementia with Lewy bodies or Parkinson's disease dementia. So we are going to be hearing three acronyms a lot in the training today, and that's going to be PD, which is Parkinson's disease, which is cognitive impairment mostly absent. We're going to be talking about Parkinson's disease dementia, which is PDD. Parkinson's disease gradually morphs into Parkinson's disease dementia. And then we're going to be talking about DLB, which is dementia with Lewy bodies, and this is how they relate to each other. There is also another section, so this is what we're going to be talking about today. There's also another section to the right of your screen where you have the synuclein collecting in a non-neuronal tissue, so not in the brain cells, but other tissues. And again, there you can have with or without cognitive impairment, and some examples like multisystem atrophy are up on the screen. We're not going to be talking about this today, but this just gives you an idea of the scope of the synucleinopathies and everything that they cover. And then just for the sake of completion, I do want to point out that there are very few cases of PD, PDD, and DLB. These are genetic cases where there is no alpha-synuclein. So you don't always have to have alpha-synuclein in order to diagnose PD, PDD, or DLB. There's a very small group of patients where there is no alpha-synuclein. We don't know what causes these diseases. But again, that's not what we're going to talk about today either. What we are going to talk about today is in the red circle up on your screen. All right, and so moving on to the LBD spectrum. So there's a lot of controversy as to what is the difference between DLB and PDD. So if we go back to the previous screen, you'll see under Lewy body dementia, there is DLB, dementia with Lewy bodies, and there's PDD, which is Parkinson's disease dementia. So how are they different from each other? And there you come into this whole concept of the 1-year rule. So if there is Parkinsonism, which is a movement disorder within 1 year of onset of clinical symptoms. So I'm in the upper part of the screen right now. So you have Lewy body disease. Now you have Parkinsonism within 1 year of clinical onset. When there's no cognitive decline, you have Parkinson's disease or PD. When you have cognitive decline without functional impairment, you have PDMCI. We talked about what MCI is a little while ago. And when you have both cognitive and functional decline, you have PDD, Parkinson's disease dementia. Now, the bottom part of the screen, there is no movement disorder within the first year of symptom onset. When there is cognitive decline without functional impairment, you get DLB, MCI, and when there's cognitive and functional decline, you get dementia with Lewy bodies. So the arrows tell us in which directions these progress. So they progress from MCI to dementia with Lewy bodies at the bottom, and from Parkinson's disease to PD, MCI to PDD at the top. And then you have some patients who meet the criteria for both DLB and PDD. And these are patients who have Parkinson's disease DLB subtype, which is in the gray box in the center of the screen. So let's talk a little more about the 1-year rule because that is very critical. So the problem with that is that the DLB folks and the PDD folks don't talk to each other, and they come from different backgrounds. So the DLB folks come from a dementia background led by Dr. Ian McKeith, who practices in the UK. And in their view, DLB should be diagnosed when dementia occurs either before or perhaps even concurrently with Parkinsonism. But when you have well-established Parkinson's disease already before the dementia happens, then you should be thinking about a diagnosis of PDD. You should also think about using a generic term such as Lewy body disease in cases where the history is not clearly available. So this is the view of the DLB caucus, right? And then in research, they still recommend using the 1-year rule to differentiate between DLB and PDD. Now, let's see what the PD people say. So the PD people, the Parkinson's disease people, are led by Dr. Ron Postuma, who works in Canada. So they are more concerned about the folks who have Parkinson's disease and early cognitive impairment. And what they found is that if you use a very stringent rule to diagnose cognitive impairment, 10% of people right at the beginning of their diagnosis of Parkinson's disease are cognitively impaired. And if you use the 26 out of 30 cutoff on the MoCA to diagnose cognitive impairment, then up to 20% of people with early untreated Parkinson's disease can be found to have cognitive impairment. So what they recommend is that the presence or absence of dementia as the first predominant symptom should not exclude a diagnosis of Parkinson's disease dementia. So they're coming from slightly different directions. They also recommend that for those people with dementia who already carry a diagnosis of DLB, when they meet both the diagnostic criteria, the diagnosis can be optionally qualified as PD-DLB subtype, which is what I had in the previous figure. All right, so moving on to epidemiology, how common are these? So both PDD and DLB are diseases of older adults, but young onset cases do occur. Both are more common in men than in women. The point prevalence of DLB in the general population, about 7 to 11% of dementia cases have dementia with Lewy bodies. What about PDD? About 3 to 4% of dementia cases in the general population have PDD. And then amongst those who have already been diagnosed with Parkinson's disease, about a third of those patients at any given point in time have Parkinson's disease dementia. And then if you follow these patients over time, then within 10 years, about 50% of patients get dementia after they are diagnosed with Parkinson's disease. And the thinking is if you followed all of these people with Parkinson's disease long enough, eventually everybody would get dementia. The other important thing is that in older adults who have a degenerative dementia, most people, in fact, about 70% of people do not have one single pathology in the brain. Alzheimer's disease, as you probably know, is the most common degenerative pathology in the brain that causes dementia. But mixed pathologies, which means any two or more pathologies, are seen in more than 70% of older adults with dementia. And Alzheimer's disease is the most common pathology across the Lewy body dementias. So about 10% co-occurrence in PD patients, about 35% in PDD patients, and about 70% in DLB patients. And the reason that's important is that when you have these two or more pathologies happening at the same time, you need less of the pathology to have the same amount of symptoms. So the clinical symptoms occur with lower levels of each additional pathology. So the amount of pathology you needed, for example, if the patient only has DLB, you will need more Lewy bodies in the brain to cause the same amount of symptoms than you would need but you would need less Lewy bodies in the brain if there's coexisting Alzheimer's disease along with it. All right, so moving on to clinical features. So this is a comparative chart of all the clinical features. It's a pretty busy slide. We're going to go over these symptoms, most of them one by one, but I just wanted you to see how they stack up against each other. The PDD criteria, which is the middle column up on your screen, they came out in 2007 and they have not been updated since, so they're pretty old. And they divide the clinical features into core and associated diagnostic features. So we have core and associated. The terminology used by the DLB folks is a little bit different. These are newer criteria. They came out in 2017. And the terminology that they use is essential, core, and supportive. So you can see that what's core in PDD becomes essential in DLB. And so it's a little bit confusing, but the symptoms are basically the same. So let's look at these one by one, starting with attention and fluctuating cognition. So impaired attention and fluctuating cognition, they are an associated feature in PDD. In DLB, it splits them up. So fluctuating cognition becomes a core feature, while impaired attention becomes an essential feature. And the fluctuations can occur not only from day to day, but even within the span of a single day. So when these people are hospitalized, you can have arguments between the different shifts because the morning shift person might say, Mr. Smith was doing just fine. He spoke with me. We had a great discussion. And then the swing shift folks might say, I don't know what you're talking about because Mr. Smith is extremely confused. He can't get two words out. I don't know what he's saying most of the days. So there can be extreme fluctuations even within the span of a single day. These fluctuations can even present as staring spells, excessive drowsiness, or periods of disorganized speech, but eventually the quality of the fluctuations is the same both in PDD and DLB. And in order to do a bedside assessment, you can just do a serial sevens from mini mental state exam where you ask the patient to count back from 100 by sevens. You can also ask them to do the month of the year backwards, for example, or the days of the week backwards. But when you do that, make sure you start out by having them tell you the months of the year forwards or the days of the week forwards before you do backwards. So you can say, Mr. Smith, can you tell me all the days of the week starting with Monday? And then once they get to Sunday, you say, okay, great. Now let's go back from Sunday back to Monday again. Executive functions is another important cognitive symptom in Lewy body dementia. It's an essential clinical feature in DLB and an associated feature in PDD. Uh, there are different ways to describe executive functions. This is one I like, which divides the executive functions into working memory, cognitive flexibility, and inhibitory control. So working memory is when you hold something in your brain just briefly to do a task and then you're done. For example, holding a phone number in your brain in order to make that one phone call. Cognitive flexibility is when you are able to incorporate multiple streams of information and shift between which one is important for you at that point in time. So for example, when I'm working in the nursing station, there are multiple people talking to me, but I need to listen to what the nurse is telling me rather than what two people are gossiping in the background. And so it's important for me to focus on what the nurse is telling me about a critical patient. And so I can shift my attention from the gossip in the background to what the nurse is telling me about this critical patient. And then inhibitory control is when you suppress the irrelevant incoming information, which is the gossip in the background. Um, you have something known as bradyphrenia or slowed mental speed, which is very typical in Parkinson's disease and the Lewy body dementias. This is covered under executive functions in the PDD criteria, but it's covered under complex attention in DSM-5, which means that we don't exactly know where to classify this symptom. Bedside assessment, it's basically history. You can ask the patient or the family member about planning, multitasking, mental flexibility, and so on. All right, so moving on to visuospatial skills, very important symptom in Lewy body dementia. It's an essential clinical feature in DLB associated in PDD. It also depends on intact executive functions. And again, like we've talked about with the other symptoms, there's really no qualitative differences between DLB and PDD. In order to do a bedside assessment, you must make sure, first of all, that their vision is adequately corrected. You can ask questions about whether the patient gets lost in familiar areas or whether they get lost within the home. If they are housebound, if they are still driving, ask if they have been involved in any accidents or they have received any traffic tickets for moving violations. And then for testing, you can do the mini mental state exam, the intersecting pentagons, which is at the end of the mini mental state exam. You can also do the clock draw, but the clock draw is a much more complicated test. It taps into many other cognitive functions. So it's not a very clean test of visuospatial skills. So I prefer to use the intersecting pentagons when you are just testing for visuospatial skills. Okay, memory. So when we are talking about Alzheimer's disease, as all of you know, memory is probably the first symptom that we talk about. But in dementia with Lewy bodies and PDD, it's an important symptom, but it's not the most critical symptom. The criteria approach memory a little bit differently. The DLB criteria say it's not an early symptom, but usually evident with progression. The PDD criteria say something very important, which is one way that memory differs between Alzheimer's disease and dementia and Lewy body dementia, which is that usually the memory usually improves with cueing, and recognition is usually better than free recall. So what does that mean? Um, in Alzheimer's dementia, you have this amnestic syndrome of the hippocampal type, which means that the free recall deficit is not normalized by cueing. So you ask them to remember the 5 words, for example, and then when you ask them to freely recall those words without giving them any cues, they can't recall them. In Alzheimer's disease, when you start giving your cues, it doesn't make a difference. The deficit is not corrected by cueing. In Lewy body dementia, it is. So that's a difference, an important difference between the memory deficits of Alzheimer's disease and Lewy body dementia. The memory deficits are most common in dementia with Lewy bodies and least common in Parkinson's disease. And the way you test for them is you can do either the story recall or the word list recall. Those are the two main paradigms for testing memory. As you all know, the difference is with word list recall, it's a random list of words, so the person has to organize it in their brains. And in order to do that, you have to use executive function. So in order to organize a word list, you need executive functions to do that. So a word list recall is not a pure test of memory. The story recall, on the other hand, it's already organized. So all you have to do is to recall it. There are very few executive functions involved in recalling a story, and that's why a story recall is thought to be a relatively pure test of memory function. It's also known as contextual recall or logical memory. Okay, language. So you can have language problems in both DLB and PDD, including word finding difficulties, impaired comprehension of complex sentences, and this double dissociation has been reported in some autopsy studies, which means that there is worse executive functions in PDD than DLB and worse language and memory functions in DLB than PDD. How to test for language by the bedside. You allow the patient to speak freely for a while. That's very important. Don't start asking questions right away. And while they're speaking freely, you listen for coherence. What they're saying, does it make sense as a whole? You're looking for paraphasias, which are look-alike and sound-alike words, or mean-alike and sound-alike words. You're looking for circumlocution, which means that they can't remember that word, so they sort of talk around it. You're looking for neologisms, which are words that are not in the lexicon of that language. The person is just making them up. And of course, you're looking for word finding problems, and you can test by doing confrontation naming, by showing them pictures and asking them to identify what the pictures are. When you do that, make sure that you use pictures of both low frequency as well as high frequency items. Okay, moving on to neuropsychiatric symptoms. So neuropsychiatric symptoms in PDD, they're all associated clinical features. They include apathy, depression, anxiety, hallucinations, delusions, excessive daytime sleepiness. In DLB, visual hallucinations are a core clinical feature, while all the other neuropsychiatric symptoms are supportive, which means that they lack diagnostic specificity. That those include hallucinations in other modalities, delusions, apathy, anxiety, and depression. Um, I want to talk a little bit about hallucinations because across the Lewy body dementias, hallucinations are the most common psychotic symptoms. Visual hallucinations being about twice as common as auditory. So in DLB, you see visual hallucinations in up to 80% of cases, while in PD, Parkinson's disease, you see it in about 14 to 15% of cases. They are typically complex. They involve people, children, or animals, and they are often small. Um, so these hallucinations, it's very interesting. They usually begin outside the house. So the person is sitting by the window and they'll see, a man sitting on a tree outside. They're usually non-threatening. They are usually more concerned or interested rather than frightened. And then the hallucinations, as the disease progresses, the hallucinations sort of multiply. So from one man sitting on the tree, there's multiple men trying to cut down the tree. And then the proximity increases. So they start to come in the house. So now they're coming in the house, they're sitting next to you. I had a patient who had people lying all over the floor in his house. And so he would sort of lift his feet so that he didn't step over these people who were lying on the floor. The other interesting thing about hallucinations is that they typically begin in dim light. So you see them at night to begin with or at dusk. When that happens, we tell family members to keep a night light on in their room so that the hallucinations go away, and they do. But then what happens is the disease progresses, and then you start to have hallucinations in the middle of the day as well. Auditory hallucinations less frequent and usually they're accompanied or preceded by visual hallucinations, and they occur sort of later in the disease process. Uh, Minor hallucinations, these are very important even though they are not in the DLB or PDD criteria. They are actually in the diagnostic criteria for Parkinson's disease psychosis that was proposed in 2007. And there's three different types. There's presence hallucinations, which means that the person feels like there is somebody in the room. but they can't see them. I just feel like there's somebody in the room, but I look around and there's nobody there. There's illusions, which is misperception of a real stimulus. So, for example, they see a bush and they think that there's a person there, but then you ask them to look closely and they do, and they say, oh no, that's a bush. So those are illusions, misperception of a real stimulus. And then you have passage hallucinations where they feel like something just passed them by and they look around and there's nothing there. Again, they don't see anybody. It's just this feeling that something passed them by. And you look around and you don't really see anybody. The other term that's often used for presence hallucinations is extra campine hallucinations. Campine is Campine. Extra campine hallucinations. Do not confuse those with presence hallucinations. They are totally different. They are not synonymous. Extra campine hallucinations are hallucinations that occur outside the sense modality field. So, for example, if it's visual hallucinations we're talking about, they're going to happen outside the field of vision. So I see an elephant standing behind me is an extracampine hallucination. There's no way I can see an elephant behind me. I don't have eyes at the back of my head. So hallucinations that occur outside the visual field are extracampine hallucinations. Those are real hallucinations. People actually see the elephant. In presence hallucinations, you don't really see somebody in the room with you. It's just a sense of presence. So they're not synonymous. The reason we're talking about minor hallucinations today is because they either precede or accompany well-structured visual hallucinations in Lewy body dementia. Delusions. Delusions are pretty common. They are supportive clinical features in DLB, an associated feature in PDD, most common in DLB, least common in Parkinson's disease. The characteristics of the delusions are similar again in DLB and PDD, paranoid and phantom border delusions being the most common, but you can also have theft, jealousy, infidelity, and so on. I want to talk a little bit about delusional misidentification symptoms, where people consistently misidentify places, persons, or events. So I talked about phantom border. Phantom border is a delusion where people feel like there's somebody living in the house. There's a person living in the house, or there's a whole family living in the attic. And so the way that that is seen clinically is when people lay out places for a meal, for example, they'll lay out extra places for their phantom guests who are dwelling in the attic, except that nobody's ever seen them. Capgras syndrome, which most of you may be familiar with. Capgras syndrome is when you identify familiar people to actually be imposters in disguise. So you look like my wife, but you're really not. You are an exact double or an exact replica of my wife. So these are very interesting symptoms that we often see in people with Lewy body dementia. So in DLB, for example, phantom borders can be seen in about 40% and Capgras in about 10% of cases. Uh, there was a very interesting study out of the Mayo Clinic that was done in 2007. Joseph's 2007 is the reference for those of you who want to look this up. And what they did is they looked at 100 consecutive cases of Capgras, and they found that most of them, 80% of them, had a degenerative dementia. Only 4% of them had a primary psychiatric disorder. And among the degenerative disorders, Lewy body dementia was the most common diagnosis. And also 50% of the Lewy body patients had DLB and 40% had PDD, and they all had visual hallucinations. So what you get out of this is that when you have a patient with late onset Capgras syndrome with a dementia with visual hallucinations, think Lewy body dementia before you think anything else. And these are some interesting examples from that study I just spoke about. So for example, the patient believes that his wife has been replaced by an imposter, or the patient believes that his daughter has been replaced by his dead sister, or the patient believes that her husband is a lady or a stranger living in the house, or the patient will look at his wife and ask, where is my wife? and so on. So the other thing I wanted to point out just as a trivia is that Capgras syndrome was described by Dr. Joseph Capgras in 1923. So last year was 100 years of Capgras. And so there were a number of articles that came out about Capgras last year, which was very interesting, talking about the history of Capgras. All right, moving on to depression. Not much information about depression. The information we have is number one, that the prevalence of major depression and the prevalence of minor depression is depression that is not covered by DSM-3R, which was the diagnostic criteria that was used by this study. The frequencies are not statistically different between DLB, PDD, and PD, even though numerically you can see on your screen, DLB has higher rates of both DSM-3R depression and minor depression, but statistically there's no difference between the rates of major depression or minor depression between the three. And across all the three diagnoses, the 1 month prevalence rates of minor depression are much higher than the rates of major depression. Okay, pareidolia. So I wanted to talk a little bit about pareidolias, which are not included in the diagnostic criteria, but they involve ambiguous stimuli that are perceived as meaningful objects. For example, seeing a face in a piece of toast. Uh, this is often seen in Lewy body dementia patients. These are not hallucinations, but they can occur in the presence of hallucinations. People often see like full-length figures of faces or body parts of people and animals. Here are some examples of pareidolia. So the yellow triangles, these were misidentified as real faces by DLB patients. The white triangles here in this picture, these were misidentified as figures of people or animals by DLB patients. These have been taken from the pareidolia test, which is a research tool. For example, you see in this picture that there are three birds flying in the sky, but the person with DLB thought that this is a face up in the sky. So that's an example of a pareidolia. When you have pareidolias in REM sleep behavior disorder, and we'll talk about that in just a little bit, but when you have pareidolias in REM sleep behavior disorder, it can be a pretty robust predictor of future cognitive decline. Okay, moving on to sleep disorders, we're going to talk about excessive daytime sleepiness. It's an associated clinical feature in PDD and a supportive clinical feature in DLB. I do want to say that sleep problems are very common in Lewy body dementia. You see them almost in 100% of cases, as opposed to only about 70% of other dementia cases. Uh, there is no difference in prevalence between excessive daytime sleepiness at baseline between PDD, PD, and PDD, DLB, and Parkinson's disease. And the initial sleep latency is also shorter, which means that people take less time to fall asleep in patients who have DLB than those who have AD dementia. And then REM sleep behavior disorder. REM sleep behavior disorder is such an important symptom in Lewy body dementia. We could spend, half a day talking just about that. It's a REM sleep parasomnia that is associated with dream enactment behaviors. The dream enactment can be motor or vocal. And what you see on polysomnography, which is the in-lab sleep study, is that there's REM sleep without atonia or RISWA. I'll be talking about RISWA quite a bit today. So REM sleep without atonia is RISWA. And what that is when we dream, all of us, the body loses muscle tone. That's just a physiological reaction that our body loses muscle tone when we are dreaming. And that's why we don't act out our dreams. But in the Lewy body dementias, the body does not lose muscle tone. And that's how patients end up acting out their dreams. Um, if you have a known neurological disorder associated with REM sleep behavior disorder, it's known as symptomatic. Otherwise, if there's no known neurological disorder, it's known as idiopathic. And amongst the symptomatic cases, almost 95% of cases are cases of synucleinopathies. So that's by far the most common underlying diagnosis in patients with REM sleep behavior disorder. It's male predominant. About 85% of REM sleep behavior disorder patients are male, and there's a high risk of injury to the bed partner or to the patient themselves. It can start many years before the synucleinopathy occurs, or it can start with the synucleinopathy, or it can even start afterwards. There's an annual conversion rate of about 10% to synucleinopathies in patients with REM sleep behavior disorder. And then there's many other sleep disorders which we are not going to get into today, including insomnia, sleep fragmentation syndrome. You can have restless legs, you can have periodic limb movements of sleep, or you can have obstructive sleep apnea, or a combination thereof in people with Lewy body dementias. A little bit about the movement disorder, Parkinsonism. So Parkinsonism is described as a movement disorder that comprises of one of three, either bradykinesia, which is a slowness of movement, rest tremor, and all of you know what that is, or rigidity. Uh, in order to diagnose Parkinson's disease, PD, Parkinson's disease, you have to have bradykinesia with rest tremor or rigidity. But in order to diagnose just Parkinsonism, you need just one of these three. So you don't need two, which means that the diagnosis of Parkinsonism has a lower diagnostic threshold than the diagnosis of Parkinson's disease. Because again, with Parkinson's disease, you need bradykinesia with rest tremor or rigidity. Spontaneous Parkinsonism is seen in about 85% of DLB cases. So again, not every single case of DLB has Parkinsonism, and axial symptoms are more common. Also, postural instability and gait symptoms are much more common in both PDD and DLB. So it's more of a truncal gait disorder where people have trouble walking, people fall quite a bit, instead of the usual tremor that you see in Parkinson's disease. Okay, neuroleptic sensitivity reactions. So these people are very sensitive to neuroleptic medications. They can be seen in about 53% of DLB cases and 39% of PDD cases, even though it's a supportive clinical feature in the DLB, but not in the PDD criteria. And there can be two different ways that this presents clinically. You can just have an exaggerated extrapyramidal response to the medication, like an exaggerated rigidity or tremor, which is usually reversible with treatment. Or you can have a severe reaction where there is sudden onset of sedation, confusion, rigidity, and immobility. People can even get the neuroleptic malignant syndrome and die. So that's a very serious reaction that some people have to the psychotropic medications. What about suicide? So the first person account I started off with talked about suicide. There's really not enough data about suicide in the Lewy body dementias. Suicidal ideations are seen in less than 2% of individuals with LBD. Suicide plan or attempt in less than 0.1% of LBD patients over 2 years. This data is from the report of a Lewy Body Dementia Association working group that was released in 2021. And then non-accidental self-injury is also higher in patients with DLB. About 0.8% of patients with Lewy body dementia died from suicide. This is from a survey of family members, friends, and caregivers of individuals who died with LBD. So as you can see, these are just surveys. These are not like really scientific studies. And there's a lot more information we need about suicide in LBD. We do know that there are some risk factors such as younger age, male gender, European American ethnicity, presence of depression, anxiety, psychosis, other psychiatric disturbances. If the non-motor symptom burden remains high, if there are motor fluctuations, if there's higher perceived disability, higher demoralization, and then early on in the diagnostic period, because it takes so long to make the right diagnosis in these patients that it's a very frustrating time for both patients and family members. All right, moving on to office screening. So the MOCA, all of you are familiar with this. It's a 30-item test of a screening test of cognition, which is what we typically use to screen for all dementias in the office. The items that are most sensitive for PD and LBD, these are visuospatial and executive functions. I have them marked out with red on the MOCA itself right there. Immediate recall, which we don't usually score on the MOCA, and then language. And then these ones marked with a star are most important, are most sensitive to cognitive impairment in LBD. Uh, with the original scoring of the MOCA, the sensitivity is pretty low. As you can see at the bottom of your screen, only about 68%. So the scoring of the MOCA has been modified in these areas. So there's a different way to score the MOCA, and that has increased the sensitivity to about 81%. So if the sensitivity or specificity is above 80%, then you are good. So this does not increase the specificity, but it increases the sensitivity to about 81.3%. If you want to know how to score the MOCA this way, the reference is at the bottom of the screen. This is not something I typically use in clinical practice, but I wanted you to have this information. And then these are the screening tests for all the other symptoms I talked about. I'm just going to leave these up on the screen and you can look at these later. The ones that have a higher specificity or sensitivity above 80%, I have marked those with red, and the references are at the bottom of your screen. I do want to talk about a couple of more things. The NPI-Q, which is sort of a global screening test for all the neuropsychiatric symptoms. This is derived from the Neuropsychiatric Inventory, or NPI. There are 12 items to this. And then you start off by asking if the person has this symptom or not. So that's just a yes or a no. If they do, then what's the severity? And then eventually you rate the caregiver distress as well. And then the Lewy body composite risk score is something that we can actually use in clinical practice. It's pretty easy to use. There are 10 questions. The first four are physical findings and the rest are clinical symptoms. So these physical findings have to be present at least once in the last 6 months. The clinical symptoms have to be present 3 times in the last 6 months. And if that is the case, you put a 1 in the yes box here, and then you add those up and you get the total score. And the reason this is important to use is because the sensitivity of this, as you can see in the red box at the bottom, is pretty high and it's pretty easy to use. Okay, diagnostic biomarkers. So I'm going to go over these quickly and then we'll head into break. None of you are going to be ordering these by yourself, so I have all the details on the slides for you to review on your own. I'm not going to go into all the details right now in the interest of time, but I do want to point out that so in the text of the PDD criteria from 2007, there were some biomarkers listed, but they were not included in the criteria. So these biomarkers have all been taken from the DLB criteria from 2017. And in the DLB criteria, they have classified these into indicative and supportive biomarkers. And then there are other biomarkers which are not in the criteria. And the indicative biomarkers are SPECT or PET imaging, MIBG, myocardial imaging, and an in-lab sleep study. The supportive biomarkers are structural imaging, FDG PET imaging, and EEG. And then the other two are the seeding amplification assay and the amyloid PET scan. So very quickly going over these before we head into break. So the DAT SPECT scan is something that we use in clinical practice all the time. It's a SPECT scan of the brain. A normal SPECT scan looks like this. In figure 1, this is the double comma sign. And then as the disease progresses, the comma begins to lose its tail, as you can see from 1 through 4. And by the time you get to severe disease, it has completely lost its tail and you get this double period sign. So that's a DAT scan. Again, it's a SPECT scan of the brain using this tracer known as FP-SIT. I have the sensitivities and the specificities of each one of these in the slide, and you can review those on your own later on. The next one is the myocardial MIBG scan. This is a scan of the heart, interestingly. It's not a scan of the brain. And then here we calculate what's known as the heart to mediastinal ratio, or the H/M ratio. That's right here. So a normal scan, you can see the heart showing up right there, and then the scan becomes increasingly abnormal. The silhouette of the heart completely disappears. We do not use this in the US. It's not been approved. It's been approved in Japan since 2012, but it's not approved in the US. And so even though it's in the criteria, this is not something that you will be seeing in the US. RISWA, we've talked about this very often already. So that's the REM sleep without atonia that you see on an in-lab sleep study. Remember, in order to diagnose Lewy body dementia, you cannot do a home sleep apnea test. You can do that to diagnose obstructive sleep apnea, but for RISWA, it has to be an in-lab sleep test. You can also ask patients about their symptoms. So, for example, waking up with muscle soreness or injuries. You can ask about disorganized bed linen or knocked over objects on the side table. But remember that about 45% of REM behavior disorder patients are not aware of their dream enactment behaviors, and 70% report good sleep quality. About 1 in 9 patients, this is very important, about 1 in 9 patients suffer injuries that are severe enough to warrant medical attention. Okay, structural imaging, the most important part is that there is relative preservation of the medial temporal lobe. So atrophy of the medial temporal lobe is something that you see in patients with Alzheimer's disease. There's relative preservation of the medial temporal lobe structures in DLB, and if there is medial temporal atrophy, then you think that the person also has Alzheimer's disease, and then the prognosis becomes poor. Even though they have visuospatial deficits, occipital atrophy is typically not seen in these people. Um, the swallowtail sign, that is a sign seen on MRI in some cases. I will let you read this on your own. The one thing to know about the swallowtail sign is that even though you can see it on an MRI scan using a special sequence called SWI, most centers, including OHSU, are still not reporting this today. So do not send your patient to OHSU for the swallowtail sign because it will not be reported. So it'll be a waste of time and money. Um, so I'm going to skip over all of these because, again, we don't have any people in the audience who typically order brain scans or any of these diagnostic biomarkers. So you can read this on your own time. This slide talks about all the commercially available fluid biomarker tests out there. There's plenty of them out there, both for CSF and for plasma. And so this is a complete list as of today, everything that's available out there. And you will see that all these tests are for Alzheimer's disease dementia, except for this one, SYNTAP, which is a seeding amplification assay that can be used to diagnose PD, DLB, PDD, and also multisystem atrophy, MSA. So there's 7 tests for Alzheimer's dementia, 1 for the synucleinopathies right now. And here's some more information about the SYNTAP for you to read on your own. Important to know, it's not covered by Medicare or Medicaid or private insurance. The out-of-pocket cost is pretty steep, about $1,500 right now. So that's something to keep in mind as you discuss this with your patient. And we are going to jump. This is a summary slide of all the biomarker reports that we just talked about. If you want to look at that in one place, you're welcome to do that over the break. I will leave this up on your screen, and with that, we will head into break. We are at 11:03. Let's take a quick 7-minute break, and we'll start again at 11:10. And I'm going to leave the biomarker summary slide up on the screen for you to review during the break if you want to do that. So we'll see you back at 11:10. Thank you.
Thank you, Dr. Aga.
All right, welcome back. Part two of the training today. I hope you guys got a brief break. I know that was really heavy, so we're now going to come back and review everything we just talked about, like I said, and put this all together to come up with the diagnostic criteria for both PDD and DLP. So let's start with PDD. So the core diagnostic features are the diagnosis of PD, Parkinson's disease, and a dementia syndrome. And then you have associated clinical features, including cognitive and behavioral. For cognitive, you have impaired attention that may fluctuate. We've talked about that. Executive functions, we've talked about that. Visuospatial skill deficits, we've talked about that. And free recall memory that improves with cueing, very important. We've talked about that. And then behavioral symptoms include apathy, depression, anxiety, hallucinations, delusions, excessive daytime sleepiness. Uh, Features that make the diagnosis less certain, such as vascular features on imaging, and then features that make it impossible to reliably diagnose PDD, such as delirium, a major depression, or vascular dementia. So how do we put these all together? Uh, for a probable PDD diagnosis, you need both the core features and typical associated features, and you cannot have features that make the diagnosis less certain and features that make it impossible to reliably diagnose PDD. The behavioral symptoms, they may or may not be present. For possible PDD, now you have both core features and atypical cognitive features, such as the amnestic syndrome of the hippocampal type that I spoke about initially. Uh, and then for those that cannot be present are the features that make it impossible to reliably diagnose PDD. And then features that make the diagnosis less certain may or may not be present. Behavioral symptoms, again, may or may not be present. So this is how you put together everything that we've talked about regarding PDD so far. Moving on to DLB, we have essential features, which is the dementia. You have impairment of attention, executive function, visuospatial abilities, which occur early and are prominent. Memory impairment usually evident with progression. The core features are fluctuating cognition, visual hallucinations, REM sleep behavior disorder, and the Parkinsonism. And then you have a whole bunch of supportive features which lack specificity. And then the way you put these together is for probable DLB, you have to have two or more clinical features plus one or more indicative biomarkers. We talked about those right before the break, or you have one core clinical feature and one or more indicative biomarkers. What's important to note here is that to make a diagnosis of probable DLB, you have to have at least one clinical feature. But for possible DLB, you can have one clinical feature and no indicative biomarkers, or you can have no clinical features and one indicative biomarker, which means that with just one clinical feature, one indicative biomarker, you can make a diagnosis of possible DLB, but not probable DLB. Okay, some important differential diagnoses, and then we talk about the case. So delirium is very important. Delirium, the onset is acute as opposed to insidious in DLB patients, and the hallucinations are pretty simple and fleeting. You have the sleep-wake cycle disturbance instead of the REM sleep behavior disorder. The non-motor symptoms of Parkinson's disease are usually absent in delirium. The underlying cause is always a medical illness. So delirium is because of an underlying medical illness, and it can be difficult in older adults to diagnose that medical illness, but it should always be there. Antipsychotics can improve delirium in a low dose while they worsen DLB, and cholinesterase inhibitors worsen delirium. They can improve DLB. We'll talk about treatment at the end. Uh, what about the differential diagnosis of REM sleep behavior disorder? So, like I said, REM sleep behavior disorder occurs late at night because that's when REM sleep is the most common. It's in older adults. If there's a family history, it's because of Parkinson's disease. Eyes are usually closed in REM sleep behavior disorder. People do not usually walk. They do not usually talk back. If there's any interaction with the bed partner, it is coincidental, and usually the underlying diagnosis is a synucleinopathy compared to the non-REM parasomnias, which occur in the first part of the night. The person is relatively young. There's a strong family history of non-REM parasomnias. Eyes are usually open. They usually walk. They usually talk back. They usually interact with the other person in the room, and the associated degenerative disease is uncommon in non-REM parasomnias. And then we have the other disorders that present with Parkinsonism, such as multisystem atrophy and PSP. This is going to be in your handout, and you can review this on your own. I just have it here so that you are familiar with some of these names, such as multisystem atrophy, PSP, and corticobasal syndrome. And with that, we're going to try and apply everything that we have learned so far to this one case. So just to remind you again, this is where we started with the 83-year-old divorced Caucasian male veteran. This is the information I got over email. Visual hallucinations and sleep problems, progressive dementia for 3 years, was living independently, had to move in with his daughter in November 2023 after he crashed his car. He was also falling, not taking care of himself, had wandered out into the snow in the middle of the night in Jan 24, gotten lost, and he was found 12 hours later, three-fourths of a mile away from his daughter's house, treated for hypothermia and a left hand fracture. All right, so now this patient comes to my clinic and I get a better history from him and his daughter. So this is the history of present illness. It elaborates on some of what we knew already, and there's a lot of new information. So he has 2 years of college education off and on. He was in the US Air Force for 4 years, 3 year history of gradually increasing neuropathy and pain in his calves. He had to get up out of bed and pace for a while in order to bring relief to the pain in his calves before going back to bed when he went to bed in the evenings. He was living independently in another state, becoming more confused, making ER visits. His daughter made an appointment for him to see a dementia specialist, which he ended up canceling once he found out what the specialist specialized in. Um, in 2023, so even before the move, there was an event where he found himself in the kitchen in the middle of the night in a state of undress. He had dragged his bed linen in there as well. And then several weeks after that, he crashed his car. And when the police arrived, he couldn't remember how that had happened. There was at least one other episode of side swiping his car, also couldn't remember how that had happened. So his daughters decided to move him to Portland to live with one of them after the crash. When they went there to move him in November 23, he was able to give his daughters exact directions to local businesses, etc. So he didn't appear to be visuospatially impaired. Since the move, he has been living in his daughter's house in Portland, not getting lost in the daughter's house. But in Jan of 24, he again got up in the middle of the night. This time he walked out of the house. He was found 12 hours later, about three-fourths of a mile away. He was treated for the left hand fracture and hypothermia. Other clinical symptoms include short-term memory problems, problems with naming and word finding. He even has trouble recalling his daughter's name on some days, even though he has been living with her since November 23. Also, very interesting, he's unable to reconcile his ex-wife who lives in Portland with the younger woman he knew as his wife many years ago. And so each time his daughter refers to this person as mom, he gets really upset and says, "That's not your mom," because he thinks his mom is still the young woman he married many years ago. So he has had about 1 to 2 events in the earlier part of the night each month since the move, where he gets up and walks around, he moves furniture, he fixes pictures on the wall. When his son-in-law intercepts him, he is interactive. He has told him that he has to open the front door for a moving van or for a garage sale. He's also had non-threatening dreams of interacting with previous co-workers, but there's no dream enactment behavior. He is calling these hallucinations. He has also started having some musical auditory hallucinations that start in the late afternoon or evening, continuing through the night. These began in the spring of this year. There are days when he appears to be more confused than other days, and there's no previous history of mental health problems. He's got a pretty complicated medical history, including rheumatoid arthritis, atrial flutter, neuropathy, osteoarthritis, obstructive sleep apnea, which was diagnosed 40 years ago, which remains untreated. The pain in his legs at night, which improves on pacing, hypothyroidism, and balance problems. No substance use history. Family history is remarkable for both parents dying young. He has a granddaughter in 8th grade who still has a sleepwalking disorder, but there's no family history of Parkinson's disease, ALS, or dementia. And a focused neuro exam in the office revealed mild bilateral Parkinsonism. Some labs, EKG, etc., were done. Reversible dementia labs were fine. EKG was unremarkable. For neuropathy, he's on duloxetine, which helps, and gabapentin, which does not. For cognition, he was started on Aricept, that's donepezil. His cognition improved. The nocturnal events have only occurred twice since then. He is also less confused when he is intercepted at night. This is his mocha. He scored a 19 out of 30 on the mocha. I have in red the mocha, the LBD sensitive items that you can see up on the screen. This was a virtual exam. So on a virtual exam, I will ask them to do the clock and the cube draw on a piece of paper, and then I take a picture of that. So that's up on the right hand side of your screen. And then at the bottom, you have the F words, which are in the mocha. He was able to come up with 6 F words, and he was able to come up with 15 animal names. Animal names are not in the mocha, but I always supplement the mocha by doing the semantic fluency test. So he came up with 6 F words and 15 animal names in 1 minute each. Here's a CT scan of his brain. For those of you who are not used to seeing CT scans of the brain, this is what we are looking at. This is hippocampal atrophy. Um, it's pretty remarkable for somebody even his age, especially if we are not thinking Alzheimer's disease. This is the rating scale for hippocampal atrophy. And as you can see, this person probably has at least the grade 3 hippocampal atrophy on his CT brain. And so let's do the questions. Whoops, I have the answer right there, but that's okay. Let's still see what you guys think about this case. Okay, so pretty evenly divided between dementia with Lewy bodies, Lewy body dementia, and Alzheimer's disease dementia with Lewy bodies. Remember, dementia with Lewy bodies is the name of the disorder. Lewy body dementia is the umbrella term that also includes PDD. So we try to be as specific as we can. So for the people who said Lewy body dementia, you're right, but the person really has dementia with Lewy bodies. So far, we think. We'll move on to other questions. And then some people, of course, think that he has Alzheimer's disease, dementia with Lewy bodies. So we'll talk about that. I'm going to move on to the next question. Please ignore the, oh, okay. So let's try and apply the DLB diagnostic criteria to this patient. Presence of a dementia syndrome, present. Problems with attention, executive function, visual perceptual ability, evident on MoCA. Remember the clock draw and the cube, but questionable by history. When his daughters went to visit, he could give them good directions. He's living with his daughter. He's not getting lost in the house. Prominent or persistent memory impairment, not evident early on. In this case, it was evident pretty early on. Fluctuating cognition is present. Visual hallucinations, even though he calls them visual hallucinations, they are absent. He's actually dreaming. So make sure when people tell you something, they like use a technical word such as hallucinations. Please ask them what you mean. The daughter might come in and say, "My dad is delusional." Please ask them what that means, because they may not mean the same thing by using those terms that you think they do. Uh, Dream enactment behavior. Again, he does not have REM sleep behavior disorder. He's getting up and moving around. He walked outside the house. He's interacting with his son-in-law. He's opening his eyes. That is not REM sleep behavior disorder. That is a sleepwalking disorder. And why do people have sleepwalking disorders at this age? It's not the age for a primary sleepwalking disorder. That's his granddaughter who has it. What he has is a secondary sleepwalking disorder due to untreated obstructive sleep apnea, which he's had for 40 years, and he didn't really get treatment for that. So the obstructive sleep apnea is waking him up, and then he's getting out of bed and walking around and engaging in sleepwalking. He does not have REM sleep behavior disorder. And then spontaneous Parkinsonism is present. Okay, so let's apply the biomarkers to the case. So let's see, SPECT and PET imaging has not been done. A myocardial scintigraphy is not approved in the US. A polysomnogram has not yet been done. We did do a CT scan of the brain. Actually, he had it done before he came in, which showed the hippocampal atrophy. We haven't done the FDG PET. We've not done the EEG. We've not done the SYNTAP, and we've not done the amyloid PET scan. All right, so my final clinical diagnosis in this case is dementia due to multiple etiologies, both Alzheimer's disease and Lewy body disease, also known as Lewy body variant of Alzheimer's disease. And why am I thinking Alzheimer's disease? Because there was memory impairment early on, and there was medial temporal atrophy on the CT scan of the brain. So that is not usually seen in patients with Lewy body dementia. Okay. I have the correct answer up there, so maybe we won't take up the questions. I'll just talk about this. So what is the first test that you would like to order in this patient to confirm the diagnosis? The correct answer is I want to do a CSF analysis to look for both Lewy body and Alzheimer's disease biomarkers. And so that would be the AD biomarker test and the SYNTAP test. Now, like I said, the SYNTAP test is pretty expensive. It's about $1,500 out of pocket, so the family may not want to do it. If they cannot afford to pay for the SYNTAP, I would like to do the DAT scan of the brain. Remember the double comma sign that was morphing into the double period sign? So a DAT scan of the brain is a pretty sensitive test for dementia with Lewy bodies. It was even approved for this in 2022. However, the problem with the DAT scan of the brain is if you're thinking Alzheimer's disease as well, a DAT scan of the brain does not diagnose Alzheimer's disease. It only diagnoses dementia with Lewy bodies. So what do you lose by doing a DAT scan instead of the CSF testing? You lose the opportunity to simultaneously diagnose Alzheimer's disease dementia in a single test. What additional diagnostic test would you like to do for this patient? So even though you're going to do the DAT scan or the SYNTAP, but you also need to do an in-lab sleep study or a polysomnogram in order to make sure that the patient truly has a sleepwalking disorder and the obstructive sleep apnea and not REM sleep behavior disorder, which is what you're thinking clinically. All right, so with that, let's see how we're doing for time. So I want to talk briefly about treatments and then we'll open it up to questions. Um, so when we talk about treatments, really in medicine of any disorder, the gold standard of treatment, at least medication treatment, drug treatment, are randomized controlled trials. All of you know that. Randomized control trials is when you compare the active drug to placebo so that you want to make sure that the improvement in the person's disease is not by chance. It is actually an improvement that is because of the active drug. The problem with Lewy body dementia is that the randomized control trials are few and far between. And so when you get to that situation, then you are forced to look at expert consensus. So most of the recommendations I have here are from this Delphi consensus process. That's one way to build consensus among experts. And so that's the data I'm going to be presenting for the most part in this section, starting with cholinesterase inhibitors for cognition. So there do happen to be randomized controlled trials of donepezil in Lewy body dementias, and they found it to be very effective. You start with 5 milligram once a day. You can increase it to a maximum of 10 milligrams a day if the patient can tolerate it. Remember, starting 2 or 3 years ago now, there is also a donepezil patch. It's called Adlarity. It's a weekly patch. It's not a daily patch, which can be confusing to some patients. It's also brand name and so really expensive. The other option is rivastigmine or Exelon. There have been meta-analyses that have found it to be effective. The dose of the capsules is 1.5 twice a day for the first 4 weeks, and then you can increase that to a maximum of 6 milligrams twice a day if tolerated. Most people do not tolerate the capsules well. There are a lot of GI-related side effects like nausea, vomiting, and so on. And so we also have the skin patch. It's been available for a long time. So unlike the Adlarity patch, the rivastigmine skin patch is available as a generic. It's also a daily patch instead of a weekly patch. So you can use that. Okay, cholinesterase inhibitors for psychosis. There are some open label trials of donepezil in Parkinson's disease dementia that have found it to be effective. There are some secondary analysis of trials of donepezil and DLB that also found it to be effective. And the expert consensus group basically says that you can use rivastigmine and donepezil for neuropsychiatric symptoms. Which ones they don't specify. So basically they're saying, if you remember the NPIQ, there are 12 neuropsychiatric symptoms. And basically the experts are saying you can use them for all 12 neuropsychiatric symptoms, but they don't specify really which ones. Antipsychotics. So there is a black box warning for antipsychotic use in patients with dementia. You're all familiar with that. We still use antipsychotic medications for psychotic symptoms in dementia, but we have to be very careful. Quetiapine is the one that's used the most often because it's got very few side effects, but some people think it's also not very effective. Uh, Clozapine, there is some evidence for its efficacy in Parkinson's disease psychosis, but there are no randomized control trials in Lewy body dementia. And then pimavanserin, which is Nuplazid, there was a study that came out just this year that found it to be effective for the treatment of psychosis and Parkinson's disease dementia. So you can think about using pimavanserin if quetiapine is not effective for psychosis or Parkinson's disease dementia, but not in dementia with Lewy bodies because there's no evidence that that will help. You also want to reduce the dopaminergic medications whenever possible in patients with Parkinson's disease dementia, and you reduce these in this order, starting with the anticholinergic drugs first. You also may notice that levodopa is not on the list of medications to remove, so which means that levodopa is pretty safe to use even in the presence of psychosis in PDD. So don't do away with levodopa, but you can gradually remove most of the other dopaminergic medications. For depression, there is no recommendation, which is sort of interesting because it is such a distressing symptoms in older adults with dementia, but there are no recommendations regarding treating depression in people with Lewy body dementia. Managing suicide risk, it depends on which stage the patient is in. So in the early diagnostic period, it's very important to make an accurate diagnosis promptly because like I said, when I talked about the risk factors, the patients are very distressed by the fact that they go from doctor to doctor to doctor and they do not get an accurate diagnosis. The living with Lewy body dementia stage, it's very important to keep screening for suicidality, but also to educate about Lewy body dementia for both patients and families, reduce the environmental hazards, and address the disconnectedness that they feel to other people. And then end of life, you want to discuss the availability of hospice and palliative care. And you want to make sure that there is a good coordination between primary care, who sees the patient pretty often, and specialty care, like myself, who might be seeing the patient once or twice a year. Treatment for motor symptoms, levodopa is pretty effective, although 1 in 3 patients when they're treated with levodopa DLB patients, they will experience an increase in psychotic symptoms. There is some new evidence about using zonisamide as an adjunct to levodopa in patients with DLB. And zonisamide, as you might know, it's an anti-epileptic medication where pretty high doses of zonisamide are used. But for the treatment of as an adjunct to levodopa, the doses of zonisamide that are used are very low, just about 25 to 50 milligram once a day. And then for the sleep disorders, depending on what sleep disorder it is, for insomnia, melatonin and the Z drugs have been found to be effective as per the expert recommendations. Uh, for restless leg syndrome, we have the dopamine agonists and gabapentin and pregabalin. There are pros and cons to using all of these, which I have listed up in your slide. For obstructive sleep apnea, of course, you want to use a CPAP. Um, for excessive daytime sleepiness, new vigil and methylphenidate, which is Ritalin, have been found to be somewhat effective. And then finally, for the treatment of REM sleep behavior disorder, it's very interesting that we use Klonopin and melatonin all the time, but there's not a lot of randomized controlled trials of these medications. For Klonopin, there was only one small 4-week randomized controlled trial. And for melatonin, there have been 3 small randomized controlled trials, but only one of them was positive. The other thing to remember, and that's why I have this in red up on your slide, is that even when patients' symptoms improve on Klonopin, Klonopin does not improve REM sleep without atonia, RISWA. So when your patient improves on Klonopin, do not send them back for a sleep study because the sleep study will say RISWA present and then you will increase the Klonopin dose. So don't do that because Klonopin does not improve RISWA, but melatonin does. But if the patient has symptomatic improvement, there's no reason to send them back for a sleep study again. Memantine, there's been one small randomized placebo-controlled trial, and then pramipexole, which is a dopamine agonist, Mirapex, it is part of the expert recommendations. And then, so this is all information for those of you who prescribe, and there's not many of you in the audience who do that, but all of you can do this. Safety precautions for REM sleep behavior disorder. This is something every one of you can tell your patients. Lower the bed height, place the mattress on the floor, remove potentially dangerous objects, sharp objects away from the room, place beds away from the window, consider window locks. You can use a sleeping bag to sort of put the patient in to prevent them from striking out when they have violent dream enactment behavior. And eventually you can ask the bed partner to sleep separately from the patient if needed. By the time the patients come to me, I find that in most cases, the bed partners are already sleeping in a different bedroom because they have learned this from themselves. After being punched and hit so many times at night, they have already moved out of the bedroom. Okay, online resources. The best place to go is the Lewy Body Dementia Association, and the website is right there. There are 20 LBDA research centers of excellence in the US, one of them being in the at OHSU. So you are welcome to refer patients to us at OHSU, or if you have loved ones in other parts of the country, to one of these places. And then I want to end with the first person caregiver account where we began. Again, for those of you who know who this is, please keep it to yourself because it's sort of a surprise. But this is the full text of the first person account. As you may know, my husband Robin Williams had the little known but deadly Lewy body disease. He died from suicide in 2014 at the end of an intense, confusing, and relatively swift persecution at the hands of this disease's symptoms and pathology. He was not alone in his traumatic experience with this neurologic disease. As you may know, almost 1.5 million nationwide are suffering similarly right now. This was an account published by his wife in the journal Neurology in 2016. And just to emphasize how complicated this disease is, everybody presents differently. And so, just to emphasize how complicated this disease is, I have this one last thing for you on the screen that you can read on your own. And with that, I'm going to stop and open it up to questions. This article and the handout is going to come to you through email. And thank you for your time. I really appreciate your patience, and I am willing to take questions until about noon today. Thank you.
Dr. Aga, thank you so much for this very informative presentation. We do have a couple of questions that came through in the chat, and then we can open it up to additional questions as well.
Yeah.
Teresa had asked around the time that you were showing us the MoCA and the scoring that was more specific, had asked, does this score apply to the basic MoCA? And she uses the MoCA basic with people with low literacy in both English and Spanish. And then she also had a follow-up question if you had a recommendation where to find a more recent version of the basic MoCA.
Um, it does not apply to the basic MoCA. That study was done using MoCA 7.1, and so it only applies to MoCA 7.1. And again, it's not something I use in my clinical practice. I just find it interesting that the way they modified the MoCA scoring to yield a different set of scores. Um, and I'm not familiar with the basic MoCA very much because my clinical practice is really in a specialty setting, so we don't use the basic MoCA at all. So I'm sorry about that.
Thank you. We do have another question that came through in the chat. How does a history of ADHD that's untreated affect executive functioning testing? I've noticed that some of the indicators are echoed in on the Vanderbilt.
Right. So executive function deficits are one of the core symptoms, cognitive symptoms of ADHD. So when you have somebody with untreated ADHD, where they're now, you think they might be getting Lewy body dementia, you have to factor out the executive functions because the executive function deficits might solely be due to ADHD, and you have to focus on all the other symptoms such as the visual spatial impairment, the visual hallucinations, the REM sleep behavior disorder, and so on. So again, in that person, I would not hang my hat on the executive function deficits because it could be because of Lewy body dementia. It could also be lifelong due to ADHD, unless you get a good family history, a good history from a family member, and they tell you that even though their executive functions were impaired at baseline, this is very different from how they used to be. That's why it is so important to get some collateral information whenever possible, because even though they might have had the same symptoms lifelong, but the wife or the daughter or the son, somebody in the family might be able to tell you, this is not how they used to be. Yes, they've had ADHD all their life, but they used to do this pretty well, and now they can't even do this. So this is a change from the baseline, and then that becomes really important.
Thank you so much. And Dr. Aga, you're getting lots of appreciation in the chat. Thank you, thank you.
Thank you.
Any further questions for Dr. Aga for today? Feel free to put them in the chat, or if you'd like to come off mute and ask, you're welcome to do that too.
Ronnie, did we want to give another call out to, and maybe you mentioned this and I missed it, Dr. Aga, the fact that a person or professionals here in Oregon can refer directly to Dr. Aga?
Yes, they can. So we are happy to take referrals in the dementia program up at OHSU. The referrals have to come through the primary care physician. That's the only way OHSU will accept referrals. So if you go to the dementia program website, there are instructions on how to refer. There's a link to the referral form, and the PCP has to fill out the link and send it to us. There's also a phone number, and we have excellent nurses. So if you leave a message saying, I have this patient, but I don't know how to refer, these instructions are very complicated, somebody leave a message and somebody will call you back and help you with the process. But again, the only caveat is that the actual referral has to come from a PCP. It cannot come from anybody else. And the reason for that is because my role at OHSU is that of a consultant. I think I mentioned a little while ago that I might see somebody once or twice a year, while the PCP sees them frequently. So what I will do at the end of the visit is I'll make a bunch of recommendations and send them back to the PCP. And then the PCP is the one who actually carries out the recommendation. So if the patient doesn't have a PCP, I have nobody to send my notes and my recommendations to. So if the person does not, unfortunately, have a PCP, it would be critical for them to get a PCP first before they refer a patient to me.
Thank you, Dr. Aga.
Thank you. We do have one
Yeah.
more question that's come through in the chat.
Mhm.
Willow asks, you said you include the semantic fluency test when giving the MOCA. Can you say more about that?
Yeah, that's a great question. So when we test for fluency, and by fluency, I mean things like asking them for giving us as many words as they can, starting with the letter F. There's two ways to test fluency. There's phonemic fluency and semantic fluency. And it's interesting that the two screening tests that we often use in clinical practice, the MOCA and the SLUMS, they have each selected a different fluency for testing. So if you're familiar with the SLUMS, they do the animal test. That's semantic fluency. If you're familiar with the MOCA, they use the F words, so that's phonemic fluency. That sounds pretty simple. Uh, the problem is they're not interchangeable. They are actually, even though they are both fluency tests, they're actually testing something very different. And so I think one of the shortcomings of the MOCA is that they have chosen to go with a phonemic fluency, and they have omitted semantic fluency. So I will always supplement my MOCA with a semantic fluency test at the end. The phonemic fluency, the F words, they tap into frontal lobe functions, more of executive functions. So frontal subcortical circuits are involved in phonemic fluency. The temporal lobe and memory is involved in a semantic fluency. And what you can actually do is calculate something known as the semantic index. When you have both the phonemic fluency and semantic fluency scores, you can actually calculate a semantic index, which is the semantic fluency score divided by the sum of the semantic and the phonemic fluency scores. And then if the answer to this is less than 0.52 when you divide these, if you get an answer that's less than 0.52, that is highly suggestive of Alzheimer's disease dementia. So in diseases where the frontal lobe functions are impaired more preferentially, you will have phonemic fluency problems. Where the temporal lobe functions are preferentially impaired, you will have semantic fluency problems such as in Alzheimer's disease. So if you remember, if you go back to this person's MoCA, let's see if we can do that since we have some time. Whoops. Okay, maybe we can't. But if when I send you the slides, you will see. So the person had generated like 15 animal names and only 6 F words. So that is what is known as a semantic advantage. Semantic advantage is normal. So all of us here listening to this have a semantic advantage. If all of us sit here and generate any number of F words and any number of animal names in 1 minute, you will find that the number of animal names you come up with will be more than the number of F words you come up with. This is known as semantic advantage. This is normal. This is how all of us are. And then as our Alzheimer's disease progresses, our semantic fluency shrinks. And so the number of animal names we generate becomes less and less and less, and you eventually lose the semantic advantage. So when you see a patient in your office and you're thinking Alzheimer's disease, and then you supplement the MoCA with a semantic fluency test, and they come up with, let's say, 10 F words and 6 animal names, they have lost their semantic fluency, and you know that their Alzheimer's disease is already reasonably advanced. So again, they are not interchangeable. They are not synonymous. You should try and supplement the MoCA or the slums with the phonemic fluency test, but you should try and do both in your patients. And then the comparison of their semantic fluency and their phonemic fluency will give you very important clues about what's happening with their dementia. Now, none of these are diagnostic. These are just clues. None of these are diagnostic. Nobody looks at the semantic advantage and says, oops, that's lost, must have Alzheimer's disease. And this guy was a great example of that. So here the semantic fluency is still pretty preserved, right? 15 animal names in 1 minute. So preserved semantic fluency, but I'm still thinking of Alzheimer's disease because of the medial temporal lobe atrophy. So how did this man still have preserved semantic fluency, even if I'm thinking Alzheimer's disease? That's because, again, it's always a decline from baseline. We are seeing him today. His semantic fluency is 15 today. How do we not know if we had not met him 10 years ago, his semantic fluency could have been 25? So for him, from 25 to 15 is a decline, but we didn't meet him 25 years ago. We're meeting him now. So it's always relative. It's a decline from baseline, and it's never diagnostic. It's a clue. And you can still make a diagnosis of Alzheimer's disease even when semantic fluency is preserved if the other biomarkers or the other clinical features sort of line up in that direction. So I'm sorry, that's a long answer to a short question.
Dr. Aga, thank you so much. Any additional questions for Dr. Aga today? It looks like we could take maybe 1 or 2 more.
Ronnie, I think I see a question with regard to the correlation between, they say head injury, and I don't know if they mean TBI or just head injuries in general, and LBDs.
I'm not familiar with any direct correlation between TBI and LBD. What you get if you have repetitive TBI is chronic traumatic encephalopathy. That's the pathology in the brain that happens because of that. Traumatic encephalopathy is a tauopathy. So the protein that's involved in chronic traumatic encephalopathy is tau. Here, the protein we were talking about today was synuclein. So it's a completely different protein, and I'm not aware that there is any correlation between head injury and Lewy body dementia. But of course, you can have both in a patient. That's why I said that over 70% of patients have more than two pathologies in the brain. So, for example, a professional football player wants to say that he cannot also get Lewy body dementia. So of course, you can get Lewy body dementia in the presence of traumatic brain injury, but there is no like direct causative association between the two. The other thing to remember is we use the word, we sort of throw it around casually, like some person has CTE, chronic traumatic encephalopathy. We have to remember the chronic traumatic encephalopathy is the pathology in the brain, just like synucleinopathy for Lewy body dementia is the pathology in the brain. But the clinical syndrome is called traumatic encephalopathy syndrome, or TES. The clinical syndrome is not CTE. So when you talk about a patient clinically and say, oh, this person has CTE, no, CTE is the pathology in the brain. Amyloid is the pathology in the brain. Synuclein is the pathology in the brain. Clinically, the person is said to have traumatic encephalopathy syndrome, or TES, and there are diagnostic criteria for those that have been published. So you can look those up.
Thank you, Dr. Aga.
Yeah.
We have one more question that has come through. Do you or other members of your team teach this program in Spanish? And I'm going to add other members of the team provide patient education on LBD in Spanish.
Yeah, unfortunately, my knowledge of Spanish is zero. I don't. I'm not aware if anybody else in the team has. I'm sure there are people who are very skilled at Spanish. If anybody wants to take a stab at teaching this in Spanish, they're welcome to do that. But my knowledge of Spanish is next to zero. I'm sorry.
Thank you. Sounds like there's an open invitation if anyone would like to help take on that very important work. Last call for questions before we close for today. Not seeing any further questions come through in the chat. Dr. Aga, you're getting so much appreciation from those who are attending today. Thank you so much for joining us and for sharing your expertise. Very, very much appreciated. As a reminder to everyone, we will be sending out the slides with the resources that Dr. Aga has put together for us following this training, as well as the information to apply for NASW CEUs. Any final thoughts, Dr. Aga or OB team, before we close for today?
Just thank you so much, everybody, for attending. It's a very important topic. So thank you for attending and for your attention and your questions. I really appreciate it.